The Genuine Article. Discussion and commentary based on articles from JACC.
Surprisingly, clinical trials have not shown that glucose reduction in diabetics invariably reduces cardiovascular events. Perhaps treatment of atherogenic dyslipidemia in diabetics can produce that benefit. I'm Tony DeMaria, the editor of JACC, and here to discuss evidence of that potential is Dr. Steve Nissen. Steve is chairman of cardiovascular medicine at the Cleveland Clinic. So, Steve, tell us a bit about the study that you published.
Well, we had previously shown that giving an insulin sensitizing drug, pioglitazone, rather than a secretagogue, a glimepiride, a sulfonylurea, that the insulin sensitizer slowed the progression of coronary atherosclerosis. It actually reduced it to essentially zero. And the question we ask is, why? Now, previously, we've shown over and over again that lowering LDL cholesterol is associated with slowed progression. That wasn't the case here. Neither drug had very much effect on LDL cholesterol. But the insulin sensitizing drug, pioglitazone, raised HDL about 14%, substantially more than glimepiride, and it lowered triglycerides about 15%. And when we analyzed the outcome, what we saw was that ratio of HDL to triglycerides, that is, raising HDL and lowering triglycerides, was associated with the benefit of pioglitazone compared to glimepiride. Well, those two elements, low HDL and high triglycerides, are the core of what people call atherogenic dyslipidemia, or sometimes we call it the metabolic syndrome.
And now, Steve, I assume most of these patients were on statins and had their LDL lowered to an optimal degree.
That's right. About 90% of them were treated with statins. So they received all the customary therapies, blood pressure lowering, LDL lowering. The question was, could we do more? And it turns out that we lowered hemoglobin A1C by two different methods, about the same amount, but it didn't seem to matter how much we lowered hemoglobin A1C. What mattered was the associated lipid changes that occurred with the two strategies for lowering hemoglobin A1C.
Now, do you think you would have gotten the same results in non-diabetics?
Well, that is a great question. We have other results that do suggest that HDL is important in disease progression. We've never shown previously that high triglycerides are associated with disease progression and that lowering them makes a difference. So I think it is probably says something about the diabetic patient. The drivers of atherosclerosis and diabetes are probably not the same as they are in non-diabetics. In non-diabetics, it's all about blood pressure and LDL. In diabetics, we know blood pressure is important, but it may be about the metabolic syndrome, about this atherogenic dyslipidemia. That may be what's driving their disease progression, and if we can attack those two elements, the low HDL and the high triglycerides, we may be able to slow their disease down to levels similar to non-diabetics.
So a quick question. Do you think now, based upon the evidence that you're presenting, that we should treat our diabetics with pio now?
I'm a little bit reluctant to say that. As you know, we've come through a tumultuous year in which the other TZD, rosiglitazone, was taken off the market. Pioglitazone appears entirely safe, but it has some other downsides, an increased risk of fractures, increased risk of heart failure. So it's probably not a first-line drug. But if you've got a patient with high triglycerides and a low HDL, and you have to choose an agent, perhaps choosing pioglitazone will give an advantage in slowing down their disease progression, certainly for those that have pre-existing coronary disease. I don't think we can move this drug up to a first-line drug, but it certainly has a role to play, and I think we've amplified upon the potential differences between the insulin-providing regimen with a sulfonylurea versus an insulin-sensitizing regimen with this last remaining TZD.
Well, really interesting data showing the importance of atherogenic dyslipidemia, particularly in diabetic patients. Thanks very much, Steve. For Inside JACC, I'm Tony DeMaria.